MCQs questions at the end of this webinar, more or less 2 hours. It's a monthly webinar for juniors, doctors, and medical students. And today we have neuro-infections subject, very important topic for those that do pediatric neurosurgery. The first group will be the most prevalent, central nervous system infection, and the second part on neglected infection. We have illuminate speakers around the world. Nor Maria will introduce each speakers, and now Jeffrey will introduce the ISPN and ISPN guide. Thanks for being on board with us. You are mute, Jeff.
Sorry, thanks, Nelci. And greetings to everyone from around the world. This has been a very successful seminar. The feedback has been really positive, and we'll try and keep that going. The ISPN, of course, is the International Society of Pediatric Neurosurgery. It's the organization that serves to bring together many individual pediatric societies, such as the Korean, the Turkish, the Danish, all the individual pediatric neurosurgical societies are organized together under the ISPN. A big part of the mission, and a lot of what's been emphasized by current president, Dr. Rick Boop, is reaching out for educational content. And so we're trying, as part of the overall educational component of the ISPN, to run these courses. We run some in-person courses, we run some webinars, and we run some Clash of the Titans. One of the other most important resources is the ISPN guide. It is an active, dynamic textbook style reference resource that's available for free via the ISPN website. The mission of those who are writing and have written for the guide is to produce something that is highly practical and current. It is not intended to be like an encyclopedia, but is rather intended to give people that are actually solving clinical problems something that they can use as a thorough but quick reference in the moment where they're taking care of a sick child. So that's the ISPN, and that's the ISPN guide. And with that, I'll turn it over to Noor to introduce our speakers for today.
Thank you so much, sir. It's a matter of honor and pleasure for me to be here and to among the organizers and to introduce everyone. So first of all, welcome everyone to this amazing course. I really want to extend a warm welcome to all the wonderful faculty, all the wonderful mentors who have spared time from their busy schedules to deliver lectures for the junior doctors, the residents, and the medical students. I also want to welcome all the attendees who have shown their interest in this course and have left us going, and it's a source of great motivation for everyone from both sides. So thank you very much. I'm really pleased to introduce Professor Ajay Sinha. Professor Ajay Sinha is a qualified neurosurgeon who is currently working as a consultant at Elder Hay. He has been posted there since 2007. He's right now affiliated with the NHS, but he has originally been trained in India through the All India Institute of Medical Sciences in New Delhi. He subsequently trained in the United Kingdom, followed by a skill-based and a pituitary fellowship in Toronto, Canada. He also holds a fellowship in pediatric neurosurgery and craniofacial surgery. He has advanced fellowship training in pediatric neurosurgery, along with skill-based in the pituitary surgery as well as the craniofacial surgery. He has shown a lot of interest and has contributed to the field of pediatric neurosurgery a lot. So we are really pleased to welcome him today. He will be delivering a lecture on brain abscess and empyema. Sir, the floor is all yours now. Welcome to the show.
Thank you so much for your kind introduction. That's very great. Thank you. And once again, I'd like to share ISPN and Nelci and Jeff and the rest of the education committee members for giving us the opportunity to present our experience with subdural empyemas and brain abscess. It's not something which we see that often these days because of better antibiotics and better healthcare coverage, but I'll try and share our experience and also show some interesting cases during the course of my discussion and my presentation today. As you quite mentioned, I'm based in Alder Hay in Liverpool, which is in the northwest of England. And Liverpool is not known only for football and Beatles. It's also got a very good neurosurgical setup. We are one of the few standalone neurosurgical units in the country. We have our independent trust called the Walter Center, which deals with adult side. And 3 miles down the road, we have one of the biggest pediatric hospitals in Europe, Alder Hay Children, where I am based. So just moving straight to the topic. Sorry, the next one. Why is it not moving? Lovely. Sorry about that. So subdural empyemas and abscesses. Well, to get an infection going into the brain, we need a transmission of bacteria from somewhere around the CNS cavities. And in most of the cases, this is done from a parameningeal source of infection, whether it's in the sinuses, in the mastoid area, or in, it could be direct inoculation during a neurosurgical procedure or iatrogenic. Or in neonates, infant, it's mostly through hematogenous spread. And spread of infection can lead to development of collection of pus. If it is in the subdural space, it is an epidural space, it is called an epidural or subdural empyema. Or if it inoculates in the brain and develops cerebritis and progresses onto an abscess, then we get what we call a brain abscess. And just coming straight to brain abscess without wasting time, this is a very good paper which was published in Neurosurgical Focus. This is from the Virginia group. And main focus of this paper, and I've just quoted the abstract here, which says that medical management has made a big difference to the outcome. But nevertheless, even despite advances in medical management with excellent antimicrobial therapy, still a large percentage of abscesses require surgical evacuation. So we can get away with a number of little abscesses with antibiotics alone. A large percentage of them still require neurosurgeons and neurosurgical input. And, despite all the care in the world, still these cases have a certain amount of morbidity and mortality associated with them. And this the next paper, which is a nice study done between two centers, one in the UK in Great Ormond Street, and the other one from Michel Girat's team, late Michel Girat's team from Necker in Paris. They looked at their 25-year experience, and they found that it's a massive series. This contains 116 children and 28 infants collected over a 25-year period. And they found that in most of the cases, in children, in neonates and infants, the main source of infection spread is through hematogenous causes. They present more with features of meningitis and meningism, whereas older children and teenagers tend to present more with a parameningeal focus of infection, very likely in a ENT source, whether in the sinuses or in the mastoids. And what has come out very clear in this paper, that out of this large group of patients, only 11 of them required a craniotomy. Majority was managed with aspirations, repeated aspirations. So, there is a significant percentage of cases we require repeat surgery, but we can get away with abscesses just by repeated aspirations. The role of craniotomy over the years has definitely come down. I don't recall doing a craniotomy or abscess in the last 10 years. Most of them we have managed with serial aspirations and various either a single tap or multiple tap, but it's rarely, and with image guidance, it's possible even to hit multiple abscesses without needing to go in for a full-fledged craniotomy. Despite advances in this particular series, they had a mortality of 4%, and I think that's across board. In children, in neonates, and in infants, the mortality is slightly on the higher side, about 6-7%. In older children, it's much less. So, and it's despite all the care, a significant percentage of children are still left with some deficits in the form of neurological deficits or long-term consequences of an abscess like seizures, so on and so forth. So, important messages to take out from these two studies, and important thing for medical students and for young training doctors. Neonates and infants, they present with features of meningism and fever, raised CRP. Older children tend to present with features of raised ICP because of the mass effect from the abscess, with seizures, and very likely there'll be an associated history or ongoing middle ear infection or sinusitis. That's something which generally points to the diagnosis. Just a note of caution, in neonates and infants, CRP will generally tends to be high. In older children, despite having a full-blown abscess, at times the CRP may be normal. So don't go just by infection markers alone. Sometimes the CRP can be on the lower side because these children would have received courses of antibiotics because of the middle ear infection, and they may not show a profound CRP rise. So if you see a mass which looks like an abscess, it's an abscess unless proved otherwise. Try and investigate it further and have a low threshold to aspirate, because people have been caught out thinking it's a tumor and left the patient for several days. So CRP and infection markers being low or normal doesn't rule out the possibility of an abscess. In our practice and across board, that includes me and most of my pediatric neurosurgery colleagues, aspiration, image-guided aspiration is the way forward. We tend to use EM guidance, but I'm sure other units may have brain lab or any form of image guidance will be ideal, but image-guided aspiration is what we do. Despite all the changes and vigorous antibiotic therapy, they still carries a mortality, and overall, if you pick them up early and treat them well, they tend to do well and they tend to not come back with problems. And ENT surgeons make sure that the source of infection is eradicated at the same time or in the same hospital stay or very soon after. Few cases from my practice. This kid was an ex-prem 25-weeker, born, had a long stay in the pediatric SCIBU unit, had E. coli sepsis, and he was not thriving very well. The main reason they did a scan was because the EF was full. They were thinking more in terms of hydrocephalus. But what was clinching was the fact that the CRP was raised, which made us a bit concerned. And this is what the child came with. Not one, not two, but at least three different abscesses in the same go. And this child was barely 31 weeks corrected. So we have to go in, and I aspirated it out. I think we needed more than one aspiration. First, we went in and aspirated the frontal one and the one at the back in the same sitting, and then gave him a course of antibiotics. Then we had to go in again because this one recollected. After 4 or 5 aspirations, we finally managed to get the infection under control. Because it was E. coli sepsis, needed a prolonged course of antibiotics. I think we needed to give him a 6 weeks course of IV antibiotics. And finally, this is a scan done a year later. We kept him in a regular follow-up, thinking he may develop hydrocephalus, but he's got away with it. He's been on a regular follow-up for at least a year and a half. And so far, he's managed to avoid a shunt. This is the last scan. So we don't see any evidence of any blemish at the back, but there is an area of leukomalacia or encephalomalacia at the front from the large abscess. Still developmentally delayed, but that was because of his prematurity, but otherwise thriving, doing very well. Another one, this was a twin pregnancy, premature labor, delivered at 25 weeks. Once again, long stay in the neonatal ICU, multiple antibiotic courses for suspected sepsis, presented with seizures. And this is what we had. And this hole on the right the hemisphere was a bag of pus. And there was another one on the left side. So this when we had to innovate, because we knew that we have to go in again. What I did in this case, well, I left a large silver line AVD catheter with multiple, enlarged the hole so that the pus would come out. So I left 2 EVD catheters on either side and let them drain for the next 7 to 10 days. I think there was a couple of times when it blocked off, then we had to go and revise the catheter. And finally, we managed to control the infection. This particular case, because the ventricles were getting clogged up, and she was getting despite repeated abscess drainage, we're not able to control the infection. I had to go in and do a small craniotomy and get rid of the residual abscess cavity. And she's done well. She required insertion of a shunt subsequently. Still very, very developmentally and delayed, but survived. And so this was the case of Citrobacter abscess. So one of the common ones we tend to see in neonates, just to give you an idea what the sort of bugs we tend to see in neonates and young infants. Citrobacter sepsis is very common. So is gram-negative sepsis and gram-negative abscesses. Fungal tuberculosis, we don't tend to see much, but we do come across a node candida or a node aspergillus abscesses, but not very. We don't have a huge amount of experience. This was one particular case of a child who came in with multiple abscesses. We just put a needle in the most superficial one, and the diagnosis was straight away. It was caseous necrosis, and settled on a course of antibiotics, subsequently required insertion of a shunt. The response, despite such mass effect with anti-tuberculous medication, was tremendous. we had, based on the recommendations of the microbiologist, we also added a small dose of prednisolone in this case, just to reduce the periventricular enhancement and drop the protein, so that if shunt was required, this CSF protein would not be very high, and it responded well. And finally, we ended up putting in a shunt. I haven't seen a fungal infection in the recent past, but there have been one or two with my colleagues. I'll try and get hold of some slides subsequently. But the bog standard infection, which you tend to see in older children, is from the paranasal sinuses. And generally, they tend to present with the history of sinusitis, headaches, and you do bloods. You may find raised CRP, you may not find raised CRP. Occasionally, they will throw a fit, which is what will draw the attention to the medical team. Because general practitioners in this country are very, very, very resistant to give antibiotics. There has been a recent spurt in cases of abscesses and empyema. There is a general directive from National Institute of Clinical Excellence not to give antibiotics unless you have a known source of infection or if you have a known bug. GPs in this country, who are the one who control the practice in the community, are very, very resistant to give antibiotics. And that perhaps has led to a slightly higher rate of abscesses and empyemas in the recent past. But this is just an observation. There isn't any written evidence to it, but we are working on it. This is a classic one. This child who came in, who had been treated for sinusitis by the ENT surgeons, had a festern, and a few weeks later presented with a fit. They did a scan and found a well-localized lesion. Once again, image-guided aspiration, antibiotics, and a very good outcome. Post-traumatic, well, we don't see very often these days. The children are very well looked after. This young girl fell off a first-floor window. She had a skull fracture and was, kept in for a few days. She had a bit of nosebleed, nothing of any concern. And then she was discharged home to present about 2 months later on an emergency with meningitis. So they did the lumbar puncture, found some bugs, put her on antibiotics, and subsequently they realized that there was something more going on because the child had a fit. And when they looked at the scan, they found there was an area of focal, I don't have a contrast image of it, there was an area of enhancement in this area. And if you look carefully, you can see CSF tracking all the way down into the maxillary sinus. So not only was there a fracture going through the ethmoid gallery, there was an abscess form or early cerebritis due to infection, which had crept in from the nasal cavity. This girl needed a course of antibiotics, which once the abscess, the cerebritis resolved, we brought her in and did endoscopic repair of the CSF leak on 2 occasions. And then first time it didn't work, then second time we had to go in again and repair it for the second time, and she has been fine since. Very unusual one. This child is a craniofacial child. It's from one of my cases, had a red frame put in for a mid-face advancement. And the red frame was kept in for about 7, 8 weeks, 9 weeks. Just about the time when we were planning to remove the frame, the child started complaining of increasing headaches. And then we did a CT. There was something suspicious. The frame was removed and we did an MRI. And guess what? There is an early infection happening. One of the pins had gone through the dura. So this is a classic iatrogenic abscess. Fortunately for the kid, this one we got away with just with a course of antibiotics, and he's resolved just with medical management. One of the few cases where you could get away without doing active aspiration. This one we got away, and the child has done very well. Intracranial empyemas, they are much more serious. And I think if you have to choose between the two, perhaps abscesses leave behind a lot of scarring in the brain, but in terms of risks and complications, I think empyemas are a lot more serious. They're relatively rare, 1 in 200,000, and most of them are due to parameningeal source of infection. The general bugs in our practice are Streptococcal miliary and Streptococcus intermedius. They are the 2 common ones we see in our practice, and in the last few cases we had dealt with. Why are they very difficult to manage? Well, apart from the child being very sick and septic, they cause seizures, they can develop hydrocephalus, cortical venous thrombosis, sinus thrombosis. Quite a few of them develop pan-sinus thrombosis, and that can lead to morbidity and serious even mortality. And at least we have lost at least one case in the last 10 years because there was extensive venous sinus thrombosis, came with Jesus3. We tried to treat it, but it didn't work out. The child finally succumbed to the infection. And very rarely they can even lead to brain abscess and ventriculitis formation. And poor outcome is generally seen more in older children. Despite the best of care, still there is a mortality from various series. It varies from 4 to 9%. We did our own study. In the beginning, we had a very small series. The mortality was as high as 18%. But now with the numbers going up, our current mortality is about 3% and about 20-25% morbidity because of neurological deficit left behind. Most of them come with hemiparesis or paraparesis or with sixth nerve palsy or with other cranial nerve palsies to start with. What's the figure? This is an old slide. 5 to 10% of infections in children can spread to the brain, to the sinuses, and 3 to 17% of this who have developed infection in the upper respiratory airways, and it can develop intracranial complications. And if it's not picked up, there is still a high risk of deterioration and a high mortality. Generally, these children tend to present when they're very sick, vomiting, septic, raised ICP, raised CRP. They have frequent fits, and the diagnosis is with a background history of respiratory tract infection or sinusitis or middle ear infection. One should have a very low threshold to investigate them with a CT with contrast. But more and more nowadays we do MRI with contrast for better definition of and for better surgical planning. MRI allows us to use that for image guidance because quite a few of them would extend into the fall sign region, which we need a bit more definition. It also gives us a better idea of the sinuses and the cortical venous thrombosis. This young fellow, I dealt with him last month. He presented once again in emergency with fitting left-sided weakness, large collection going into the interhemispheric pressure. And if you look at the sinuses, they're full of collections as well. So this was done in emergency. He was very septic. His CRP was more than 300 when he came in. So the ENT surgeons went in first, drained the pus out, and we followed up with a craniotomy in the same sitting. The microbiologists were on hand to take the pus to the lab and give us infection. This came out as strep miliary. 6 days later, it still continued to be, the brain was so tense, I couldn't fix the bone flap. The bone flap was left floating. And if you go back, if you can see the collection is not only in the subdural space, there is also collection in the galeal region as well. So there was pus, moment we cut the skin, there was pus coming out. And so there was some galeal collection as well. Because we had left the dura open, we could not even leave a subgaleal drain. So we had to go in again because the child was still not very well. His CRP still remained well. So we extended the craniotomy further and drained out some more pus. He settled down. 2 days later, he developed another collection in the back. This was much easier to manage. We just went in and put in a borehole and aspirated this out. And at the same time, we opened up the scar, we fixed the bone flap back and left a subgaleal drain to drain out because the wound was breaking down as well. This is quite a challenging case. In fact, I saw him yesterday and he had a scan done. This is the 6-week post of scan. As you can see, the infection is settled down. His CRP is come down. He came in to have his antibiotics removed. And it stopped. And this was a check scan before we stopped antibiotics. So he's done well. He's still got a slight limp, but he's much better. His fits are under control. He's on anticonvulsant, which we plan to keep him long term. These are the ones which are dangerous, the one at the back. And you have to really get a high quality MRI scan to find a window because there'll be cortical draining veins. You need to find a nice window so that you go in because the brain is going to be so tense. You don't want to damage any draining veins. At the same time, you don't want to leave this collection which needs to be drained out. These are the ones that are very challenging, and especially at the back. Sometimes, this was an interesting one. We thought it's a subdural empyema, turned out to be an epidural collection of pus. So this turned out to be a lot easier than we thought. This was the pus had just collected in the epidural space from a frontal sinus infection. So sometimes we do get a pleasant surprise. It looked like a epidural, but the impression was we're dealing with empyema, subdural empyema. So our usual practice, moment to suspect infection, because ours is a tertiary unit, we tend to tell the preferred hospitals, try and get an urgent imaging, preferably MRI with contrast. We organize for urgent blue light transfer, which is in the current scenario is 45 minutes, but it never works in 45 minutes. Most patients take 2 to 3 hours to arrive. That's the nature of the pressure on the health service in this country at the moment. Even blue light is not really blue light. Most of them are booked in for surgery the same evening or the same within the next few hours after arrival. We haven't given steroids, but there are a lot of studies where people have used steroids. We, as a matter of policy, we do not use steroids. An antibiotic based on what we start in a broad spectrum and move on to specific antibiotics after discussion with the microbiologist. So anticonvulsants, if and when I don't start them upfront, I don't give them prophylactic anticonvulsants, but if they have a fit, then I put them on. But the general tendency, the opinion is divided whether to start them on anticonvulsant upfront. I don't tend not to do that, and that has been the practice on our unit. We would only give them anticonvulsants if they have a fit. We'll not start them up front. We don't give prophylactic anticonvulsants. So the management involves getting the ENT surgeons on board because they need to come in and do a FES or do sinus drainage. Microbiologists need to collect the sample and give us an answer straight away, because we need to put them on an appropriate antibiotic. Towards a larger craniotomy. Brain is likely to be very tense, and you don't want to damage the underlying cortical veins. So do a larger craniotomy. The bigger, the better. At times, as we saw in the last case, we may not be able to fix the bone flap, and the dura may have to be left open. And because most of the times you have to go in again. I have seldom thrown bone flaps away. I don't think I have even done, but there are people who would think that the bone is infected. I get away without throwing the bone flap, just leave them back floating. At a later date, if I have to go in again, I'll fix them back. But if their brain is very tense, I leave them floating. If there is a subgaleal pus, we need drains to be placed, and the subgaleal drains have to be left in between 5 to 7 days. If you take it out early, the wound will start breaking down. One of the few things in children which is very important is to get a good venous access. There's no point in treating empyema and find that they could put a long line in and it packs up within 2 days. Then you have to be back and forth to theater. We tend to use PICC line for all these children. They get a PICC line put in at the same setting because we need antibiotics for a good few weeks. Having a good venous access takes care of such a lot of problems. Otherwise, they will be called every few days, every few hours that the line is not working or it's jammed up. So getting a good venous access is the key, and that saves a lot of problem. And we don't want patients to miss their dose of antibiotics or have just one dose in the morning and wait till the following day to get a line in. So we tend to insist on a good venous access up front, and anticonvulsant as and when required. We don't give it up front. And that's been our policy. A few literature on it. This is a paper published from our unit by one of our ENT surgeons, and he did a meta-analysis, and the good thing which has come out in this paper is actually with aggressive management, the mortality has come down from what was quoted in literature at 20 to 30%. Now we are, in this particular meta-analysis, we're down to 2.3%, which is excellent news. At the same time, 20% are still left with neurological disability, and there is a 30 to 40, that is nearly 40% chance of return to theater. So some good things, some not so good things. The return to theater is one thing we are mentally prepared, and going in again, if there is a residual collection or the child is not doing well or the CRP still remains high, it's not a bad thing. It's something which should be anticipated, and the parents should be mentally prepared to do so. This was an older paper, which I was one of the co-authors on this, written by one of my ENT fellows and a current colleague of mine, in which this was a very short series. In this case, we found that the mortality was about 20%. This is what I was quoting. So this has definitely come down in due course of time. Current mortality is about 4% in our series. Just a corollary to what we were talking, not only you can get infection in the brain, you can also get in the spine. This 10-year-old child came with severe back pain, raised CRP, and he had a collection going all the way across about 7 or 8 segments of the spine. So we do a laminotomy spreading from L2, L3 up to T4, T5, large epidural abscess, epidural empyema abscess collection. And this is the scan done 5 years down the line. As you can see, it's all fused in nicely. Perhaps there is a bit of bone missing at the bottom edge, which we had to nibble in to find an opening in. So we spinal abscesses are equally, or empyema are equally common. Well, the whole world is talking of COVID. It tends to affect every organ in the body. Does it spare the brain? Answer is no. It does have an impact on the brain as well. And we found in our practice, that in the last 4 to 5 months, or last 1 year, 5 months is a short period, we had about 5 patients COVID positive coming with empyema. And possibly there is not only damage to the endothelial lining and astrocytic infiltration, perhaps the general drop in immunity makes these children more prone to subdural empyema. As you saw, this 10-year-old kid who came in with respiratory tract infection, COVID positive, and then developed a subdural empyema. And we thought this was just a chance finding. It didn't really correlate it in the beginning to this, to her being COVID positive. But then over a period of time, we found 4 or 5 such cases. So this is something which we have collected and it's in the process of being published. So wait to hear something in child's nervous system on this topic. Once again, Streptococcus intermedius is the commonest bug which we found in this group as well. So having an awareness about this condition is a must. And the more you are aware of it, the less likely you'll miss it. Long term, there's the risk of epilepsy and permanent deficits. See, cortical venous sinus and sinus sinus thrombosis are the single biggest cause of significant morbidity and mortality. And that's something which you have to keep in mind. And future lockdowns, maybe children don't have that much of exposure to the various antigens around, and that maybe have an impact on them becoming more prone to infections. That's something which for future we need to wait and watch. I guess the jury is out on that. Once again, thank you so much, and I'm going to stop there.
Thank you very much, Ajay, for these very comprehensive lectures. Just one question we will answer before the next speaker. Is from Gertz Meringe. Did you still tape large abscess in the late stage? It means with thick wall. It's a common question. Did you still indicate aspiration and not craniotomy? And on the same line, for empyema, did you indicate always craniotomy? Just before move on, a question of time, yeah. Answer this one and we move, sure. Please.
I think for abscesses, we still try aspiration. Even if it is large and thick wall, we try aspiration. And we seem to be getting away with it. Maybe because of better health access, we tend not to get them so chronic. So our experience is limited to the sort of the spectrum of patients we see in our practice. But as I said, and as I quoted the large study done between the 2 big pediatric neurosurgery centers, there are about 130 cases, only 11 craniotomies. So the need for craniotomy is less than 10%. And that's still in the bag, but that should not be offered up front. For empyemas, I still do a large craniotomy because the brain is so tense. And you don't want to, and the number of times you have to go in again because there's residual collection or recollection, you're better off having a bigger access. You're less likely to damage the cortical veins. You're more likely to decompress the brain. And because the brain being very tense and bulging is a constant feature. So the idea of having a large craniotomy, not only to drain the pus out, but also provide a bit of decompression and better venous drainage. That's been our policy.
Nelci, can I make one comment?
Yes, please.
So these 2 entities were presented beautifully together by Mr. Sinha, but this is essential for junior doctors to recognize whether you are dealing with an empyema or an abscess, whether you're actually managing the care or notifying somebody on the phone, right? One of the worst complications of my residency arose when the care was called in and said, we have a sick patient here with an abscess who in fact had an empyema that led to a delay in surgical intervention and a much worse course for the patient. Okay, so while these are presented together for the learner's perspective, they need to think of these like lightning and lightning bugs. They sound alike, but they're as different as can be. Thank you.
I couldn't agree more. I think that's absolutely, in abscess, you have a bit of time. In empyemas, make haste. As I said, it's a blue lighted. All the patients are, the usual practice is blue light the patient. We wanted them ASAP, no questions asked.
And a last comment for those that have difficulty to have an image, try to avoid lumbar puncture if you are dealing with intracranial hypertension. Maybe the clinical may mix with meningitis, but be sure that there is not papilledema, do a fundoscopy before lumbar puncture, because can have a huge damage for the brain, time to time irreversible. Thank you very much. I hope you can stay with us to discuss at the end. More questions will come and we try to move on. Please, Noor, can you introduce Dr. Kiehna?
Thank you very much. It has been a wonderful lecture. Thank you so much, sir, for the amazing lecture. I hope the attendees must have really liked it and it was really informative. I'm now pleased to introduce Dr. Erin N Kiehna. She's a board certified pediatric neurosurgeon. She's currently affiliated with the Novant Health Mint Hill Medical Center as a neurosurgeon in Charlotte, North Carolina. She has received her medical degree from Yale School of Medicine and has been in practice for about 11 to 20 years, and she has a lot of contribution in pediatric neurosurgery. We are really pleased to have her today to deliver a lecture on VP shunt infections with and without VP shunt malfunction. Dr. Kiehna, welcome to the floor, and the floor is all yours now. Thank you so much for coming.
Hi, thank you guys so much for having me and for that wonderful introduction. It is an absolute pleasure to be a part of this group and to talk to you all today. I learned so much from the first lecture already. So as she said, I'm going to talk about VP shunt infection, which is that moment that we all dread when taking care of our patients, and how we can overcome that over time. No disclosures for me. I will say two quotes that I have lived with for the last 20 years is the only way to avoid shunt complications is not to place the shunt. And that there is a fixed number of shunts in this universe. If you place a new shunt, one will fail in this universe somewhere. So as we know, CSF shunt placement has been the mainstay of treatment for hydrocephalus for over 70 years. There are probably at this point hundreds of thousands, if not millions of lives that have been saved because of this technology. I truly believe hydrocephalus, people say, well, shunt's the problem. The shunt's not the problem. Hydrocephalus is a chronic disease. A shunt is a very, very, very effective treatment for it. They have allowed our infants with congenital hydrocephalus to survive infancy, grow into childhood, go into adulthood, avoid further brain injury. When I was doing a fellowship over in New Zealand, I met a woman who'd had a shunt placed at age 2. And she encountered her first shunt failure at age 42. And that is, I think, one of the longest running working shunts that I have ever seen in my life. At the time, I couldn't believe that she was still shunt dependent. And she was. Fortunately, we did not give her an infection. But I would say that these are a very effective treatment. However, shunts can cause new and chronic surgical and medical problems, in addition to the hydrocephalus that they are there to treat. Mechanical malfunction means 60% of shunts require surgical revision within a 4-year period after they're placed. An infection develops in 5 to 15% of all of CSF shunts. I couldn't find volumes for around the world. I could find our US volumes. And so we have 20,000 hospital admissions annually for VP shunts in the US. About 4,500 are for new shunt placements. I contribute my fair share. About 10,000 are for shunt revisions, and 3,200 are for other shunt surgeries. About 2,000 of these admissions are for infections. And as we know, an average length of stay is 14 to 15 days because the shortest duration of antibiotics is going to be about 10 days. The longest, of course, is up to 21 days or longer. And this is an average cost of 46 to 62,000 US dollars per admission. So this is a huge burden on our healthcare system. But whenever you have a shunt patient come into the ER, we should be considering shunt infection, putting that on the top of our differential, especially if you're within 8 weeks of a shunt placement. Shunt infections are about 3 to 8% of the malfunctions. So once again, if you have a short-term malfunction, you've got to check for infection. And the most common symptoms are fever, headache, nausea, and lethargy. I would say fever, of course, is going to push you a little bit more towards shunt infection, headache, nausea, lethargy to a shunt blockage. But now we are all in that time of year in the Northern Hemisphere where this is basically every child in the emergency room, regardless of whether or not they have a shunt, as they will all come down with influenza and all the other viruses. When we look at the different parts and what the symptoms of presentation are, a proximal shunt infection will have focal swelling, usually right underneath your curved incision line, pain, erythema, and there can be purulent drainage, but quite frankly, we're all pretty good at closing the wound. So often it's loculated underneath it. And so at discharge, I always tell my patients, if you ever feel like there's like a sausage building up under the skin anywhere along the shunt tract, that's a reason to recom in. Signs and symptoms of a peritoneal shunt infection produce peritonitis, so an abdomen that's tender. Or a child that's curled up in the fetal position and not wanting to feed. And an infection related to the external surface of the shunt manifests with signs of local soft tissue inflammation down that shunt tract. So once again, you can see, instead of in most children, you can't really see the shunt tubing in the modern era, you see swelling going down that. The HCRN released a consensus statement on what is a shunt infection, okay? And one is obvious. It's when there's microbiological determination of bacteria present in the culture. So gram stain of the CSF, a wound swab, which be very, very careful with. I always say prep the skin before you do a wound swab, and or pseudocyst fluid. Shunt erosion or visible hardware, it can often be hard to see. You can see this photo on the left. There is the tiniest pinhole that you can see, a yellow antibiotic impregnated catheter just beneath. I couldn't see this until we went to the OR because she had very thick hair. An abdominal pseudocyst doesn't even have to have a positive culture because often these are indolent infections. That should be considered an infection. And bacteremia for kids with VA shunts. And then typical way to diagnose these at bedside is just with a shunt tap. This is a great diagram, except they don't show the person wearing gloves. And so I would say, I don't shave the scalp before I do a shunt tap, but I do prep it out. I make sure that somebody other than me is making sure the child is still. I wear sterile gloves, and I use a butterfly needle, a 25 gauge, to go into that reservoir and draw a sample. I draw it straight into the syringe, and then I put a sterile cap on the syringe. I don't transfer containers or anything because contamination does happen in the lab. And so I would say that that's a real definitive way to get it if the infection is in the valve or the proximal catheter. It's not always going to be positive for a peritoneal catheter, though. Our risk factors for shunt infections are generally pediatrics, okay? So it's our children that are less than 6 months old, premature, or very low birth weight. We think this is related to having a very naive immune system, a poor skin barrier, and quite frankly, it seems that most kids in the NICU are always fighting something off. So I think it's opportunistic too. Frequent revisions. There's an infection rate of about 7% per revision, and that varies by study. Post-infectious hydrocephalus has an up to 11 to 12% reinfection rate. Post-hemorrhagic hydrocephalus, quite frankly, I think that that clot burden, as it starts to degrade in the ventricles, is a great spot for bacteria to cling on to, create colonies, and start an infection from there. And then spina bifida, encephalocele, or any condition where there's a breakdown and possible exposure to cerebrospinal fluid. And then I say kudos to the HCRN for providing us with much of this information and statistics. The sequelae of shunt infections is very serious, in addition to kind of the hospital burden and costs that I discussed earlier. One shunt infection sets you up for higher rates of future shunt revision. We've created inflammatory milieu in the ventricles. We've created membrane scarring and webbing. Recurrence of infection, ventriculitis, meningitis, and encephalitis can happen. Higher mortality rates are associated with it due to that inflammatory cascade in the brain. We know this can lead to a decrease in IQ, worse developmental outcomes than their age-matched cohorts, and then they are at an increased seizure risk. Fortunately, this little baby on the right that I operated on this morning is still infection-free. The pathogens associated with this are usually staphylococcal species, especially coag-negative staph and Staph aureus. And this is about 2/3 of all shunt infections. When we look at all the coag-negative staph, this is most commonly Staph epidermidis. These are skin colonizing bugs. Reason they happen there is probably contaminated during the surgery from things touching skin edges, from us touching the skin, us touching the shunt. Or if there's any concerns with that skin barrier in the post-op recovery period, maybe there's like a little stitch abscess, or maybe the skin didn't heal up perfectly and seal across, any opportunity that it can get in and get to our hardware. Most bacteria-causing shunt infections produce visible growth in broth on agar within 48 to 72 hours, so 2 to 3 days. And I would say for the vast majority of infections, I feel like they show up within 10 to 14 days when you're talking about a gram-positive organism. What we used to call propioniform bacterium is now C, Bacterium acnes, causes low-grade indolent shunt infections with few overt signs or symptoms. This is also going to be that bug that you're looking for when you have an infected cranioplasty. They can show up weeks to months later with few signs or symptoms. A lot of times it's just like you keep looking at the scalp or the skull and you're like, it's just not healing great. And we say that all CSF cultures should be monitored for up to 10 days because organisms like this can grow really slowly and be hard to detect. It can also be one of the organisms that favors those pseudocysts. So once again, we say when you see a pseudocyst, assume an infection. You don't actually have to culture out of it. How do these infections happen? The pathogenesis is related to the bioform capabilities of Staph epidermidis and Staph aureus. And so there's kind of 3 stages to this. So first they attach to the surface of the implanted device, either at the time of surgery or from skin breakdown afterwards. And so this biofilm they form these are protected communities of bacteria or fungi. They attach to the surface and they form the structure or colony composed of cellular elements, and then a self-produced matrix. So they really set up a home base. Then they start activating the tissue around them. Macrophages come in, myeloid suppressor cells and stuff, while they're still attached to the catheter, for instance. And then these colonies can detach, starting to cause ventriculitis, and then our immune system really kicks in. And that's when at the point where you start to see enhancement on MRIs or CTs and start to see the periventricular edema happen. There's a very high incidence of biofilm infections in neonates. And this is where the infection and inflammation that is caused by those organisms is probably going to lead to the worst developmental outcomes. Once again, probably linked to their immune system and their poor skin barrier. Prevention is probably the absolute best thing we can do, and several different organizations between the Hydrocephalus Clinical Research Network and the SSI within the US, amongst all of our colleagues worldwide, have identified 11, 12 factors that are your very best protection against a shunt infection. And so the first, I'll focus on the preoperative environment. So it does matter what temperature your operating room is, okay? So we try to maintain it maintain the temperature in the room at a level where the infant child is maintaining their own body temperature. You don't want them to be going up and down. We have to avoid hypothermia, and we avoid hyperglycemia as well. We say to administer antibiotics at least 30 minutes prior to the first skin incision. Typically, that's Ancef. If they're allergic to Ancef, that is vancomycin or clindamycin. And we say to limit operating room traffic. So preferably the team that is in there for the case is the team that's in there for the case. You don't have people coming and going. There have been a lot of interesting studies about whether trainees do it or attendings do it. However, the more senior the staff is, they might do it less frequently, or they might do it, or they might have had the most practice with it. So at the end of the day, we have found that it's actually who does the surgeries most routinely should be doing them. For the operating field sterile precaution, alcohol-based chlorhexidine for prepping the surgical field has drastically reduced infections. It's key that you wait 3 minutes for this to apply, to dry before applying the drapes, and then an iodine, which is an iodine impregnated drape over that when possible. For the operating room staff, full standard hand scrub required by all participants. We don't allow Avogard. In fact, I caught my own PA trying to use Avogard this morning, and I sent her back to the scrub sink. All participants double glove. Outer gloves of all participants changed prior to the draping being completed. So before you start touching your instruments, your shunt and everything. And then for the shunt system, only open the inner packaging when you're ready to place it. Avoid contacting the shunt device with the drapes. We try to keep it on blue towels or in the original packaging, and enjoy minimal device handling. So typically I touch it, even though I do mine laparoscopically. I minimize the pediatric surgeons messing with my shunt. When this protocol was introduced in Canada, you can see that before the protocol, their shunt rates were anywhere from 5 to 8.5% after introduction of the protocol. But before they started using chlorhexidine with alcohol, it dropped from 2.5 to 5.5%. But when they started using chlorhexidine with alcohol, they actually have reported 0 infection rates, and this is published in 2022. This, however, is not specific to pediatric population. This is all comers with shunts. And I do think, once again, that we have a very unique patient population. So this is what the Hydrocephalus Clinical Research Network did, where we're focusing more on our pediatric patients. When they first started trying to address pediatric shunt infections, they noted an 11.7% infection rate between 2001 and 2005. Between 2005 and 2010, they introduced an 11-step protocol, which is much the same to what I introduced before. The IV antibiotics, the ChloraPrep, wait 3 minutes, thorough hand scrub, no Avogard or antiseptic cream, double glove, IABAN, antibiotic impregnated catheters, which we'll discuss more, and then a dose of IV antibiotics postoperatively. With compliance, they dropped the infection rate from 8.5% down to 5.7%. They then insisted on antibiotic catheters and said that we now are maintaining our infection rate at 6% with antibiotic catheters, but we're finding now that it's 8.7% without antibiotic catheters. But interestingly, about the same time, Johns Hopkins reported their infections rates with the use with and without antibiotic catheters and about 300 shunts. And they said there's a 12% infection rate without antibiotic impregnated catheters, but only 1.4% infection rate with antibiotic impregnated catheters. So once again, how we do the operation, how we handle the shunt probably is one of the best indicators, but there does seem to be a significant benefit to antibiotic impregnated catheters. Personally, I follow this protocol. I do have a few modifications. I insist that when possible, the neonates get a dial soap bath because it seems that the neonatal ICU has stopped bathing them daily. They say they're supposed to go every few days between baths to help protect the skin barrier, but I would like them bathed the night before. And for our older infants and children, they do a chlorhexidine wipe down my shunt tract or operative site. I do it alcohol followed by Dura prep on the head. For the abdomen, we use the chlorhexidine prep. I actually change my gloves again before I put that ventricular catheter in. We try to use a no-touch technique whenever possible. And I use absorbable suture on the skin monocryl, and I actually seal it with Dermabond. And I feel that that helps prevent children and toddlers who want to scratch at or explore their incision from actually trying to break down my skin barrier at all. Once we go from prevention, the shunt infections happen, then we have to go talk about treatment. So I will stick to it. I think it is critical to remove the shunt. I think we can all talk about the 1 or 2 times when maybe we got away with it. It's not worth it. It really isn't. I think it's absolutely critical to remove the entire shunt, remove the bacteria and biofilm from the environment. Only if somebody's unstable will I just pull the ventricular catheter out for a day or 2. I say you got to get the entire system and place a brand new EVD in. And typically you want that to be an antibiotic impregnated one. We start with empiric antibiotics. For gram-positive, vancomycin. For gram-negative, ceftazidime, cefepime, or meropenem are our top choices because, quite frankly, they should kill everything off that's bacterial. Okay. Then based on your culture results, you should be able to narrow your coverage. Based on where you live and the prevalence, if you don't have MRSA in your community, you might not need to use vancomycin. You might be able to take it down to oxacillin from the start. But if you're concerned about MRSA in your patient populations, then you should go to vancomycin. I am a big believer in external ventricular drainage. You went to the OR to remove the shunt, go on and place that EVD. And then if somehow by the end of this course, you're able to remove it, that's great, and give your patient sort of a plastic holiday before replacement. But it allows you to continue to clear that contaminated CSF. And what's really important is this gives you a way to check daily to make sure that the cell counts are improving, that you don't have a resistant organism or an organism you haven't cultured yet. And that you know when you've cleared the cultures to say the 10 days, 14 days, 21 days of antibiotics starts from today. I also say ETV endoscopic fenestration has a role. When I have seen purulence in the ventricles and I've gone in to take the shunt out, you can very easily slide a pedioscope or a small little LOTA or whatever your scope of choice is down that shunt tract, attach it to some irrigation and wash out, whether it's 5 minutes, 10 minutes until that CSF is clear. And once again, you are going to allow this patient to clear that infection faster. And at the end of this infection, you can consider doing any more membrane fenestrations that you need to open everything up, or whether the patient's a good candidate for an ETV. I'm going to show you a couple case examples. This is an 8-year-old male that 6 months prior to this presentation, I had done a huge frontal craniotomy for a supratentorial anaplastic ependymoma. So big frontal lobe tumor plus within the intraventricular extension of it. And he actually got by shunt free for a bit. And then 4 months prior to this presentation, I endoscopically fenestrated some membranes and put in a VP shunt because he really needed to get on radiation and chemotherapy for treatment. He had completed RT about 2 months prior, and he was neutropenic in between chemotherapy cycles with COG. So he had called the oncology office and they're like, I don't know, his counts must be down. He's curled up in a ball. He's not feeling well. But when oncology saw him, he had swelling along his shunt tract and his abdomen was very tender. So he had 24-hour history of fatigue, tenderness along the shunt tract. And when I looked at him, he had some excoriations on his scalp, but he had finished radiation and his skin was really, really dry and kind of looked inflamed. This is his shunt series, which looked fine. But this is what's key, is this was on the CT scan. We were looking for a pseudocyst, which he didn't have, but you could see inflammation around the shunt going all the way down the chest wall. And then on his brain, you can see that there's enhancement along my catheter. Don't worry, his dura always enhance from a low pressure situation after the tumor is resected. But here's where I got a little bit fooled, was all the magnetic artifact from the programmable shunt valves we tend to use in the US actually obscured a good portion of the scalp. But here I am, I've got a kid who's got clearly a collection along a shunt valve. He's got peritonitis. He's going to have a shunt infection until proven otherwise. So I didn't tap him. I actually took him straight to the operating room. His gram stain was actually interesting. It showed no organisms, but white cells. But of course, the culture grew back moderate growth Staph aureus. It was pan-susceptible, which was great. And we ended up giving him oxacillin for 14 days at meningitic dosing. But here's what's interesting is I got a new MRI after I took the shunt valve out, and you could clearly see gross contrast enhancement going everywhere, but the valve had been obscuring it with its metal artifact. I had an EVD in him to follow resolution of cultures. And so I actually used that at the end of the treatment course with oxacillin to do a dye study. So injected contrast dye in it to figure out where my loculations were. And then endoscopically, the middle MRI is before and the far right MRI is after, fenestrated through a couple loculated membranes. So I would say the silver lining of all of this is that he's actually shunt free now, and has remained so for actually a year now. So I would say what happened, he was not declared a surgical site infection because this happened so far after the shunt placement 4 months later. So Staph aureus doesn't show up 4 months later. If they showed me as C. acnes now or something, you say, okay, that was fair game. But I believed, given the fact that he's neutropenic, he had excoriations, he'd broken down his skin barrier. And that allowed that shunt just beneath his excoriations to be colonized. But once again, shunt free, so I guess that worked out for him. We've talked at great length about our neonatal population, and this is a ventricular subgaleal shunt infection. So this is a 6-week-old X27 weaker with bilateral germinal matrix hemorrhages, right grade 4, left grade 3, post-hemorrhagic ventricular dilation, with neonatal acquired E. coli meningitis and sepsis. So at the time I was consulted, he had the meningitis and sepsis and the bleeds, and he was treated with LPs per the neonatologist and cefepime until his CSF was clear. So he completed the cefepime. I actually did one single fontanelle tap just to ensure that the CSF was absolutely clean. And then put my subgaleal shunt in, and 10 days later, the ultrasound showed ventricular enlargement and debris, and the MRI, as you can see, shows significant debris. And so returned to the OR for VSGS removal, and this was actually all purulence in the ventricle. So I pulled my subgaleal shunt out and washed out. And due to the fact that there was still a lot of blood products and everything, I actually put in 2 EVDs so I could attempt to wash through slightly. And so he had gram-negative bacilli originally, treated him through, CSF was sterile, no white blood rare white blood cells, no organisms, no growth at 5 days. And then he comes back reinfected, same organism, same susceptibility profile. So I think sometimes in these neonates, especially when they're harboring clot in their ventricles, it's hard to know that it's sterile, even when you're going to go in there. And I think this is going to help with our rationale for doing neuroendoscopic lavage. And so this morning, I took on the advice of watching Dr. Tamale and other colleagues from Europe and their endoscopic lavage in these neonates, and did my second one to say, what I think we will significantly benefit these babies from washing the intraventricular hemorrhage of prematurity out of their ventricles, washing out the debris from prior infections before we place our catheters when possible. So we added gentamicin to his regimen as well. I do rely on infectious disease for the best antibiotics and the dosing for each individual patient. We treated him for 4 weeks for his recurrent meningitis, ultimately underwent endoscopic fenestrations. And as hard as I tried, he basically needed 2 catheters at the end of the day. And I show this picture because he was 7 months old now, and he fell backwards, and he managed to pop my elaborate shunt system off the valve. So once again, you put a great, beautiful new shunt together, and another one will fail. And so fortunately, that was just a reconnection with a longer piece of tubing for our team. But I hope this gave you guys a good overview of shunt infections, and I'm really grateful to everybody's collaborative care on our most fragile patients.
Thank you very much, Erin, for these very comprehensive lectures on shunt infection. We are already running late because we have 2 lectures in 1 hour. We have 3 lectures and 1 hour left. Just one question, quick question. Probably we can try to answer directly to our audience, individual questions. But you explained the VP shunt, what your criteria to put again a new shunt if the ATV doesn't work after the treatment. What your criteria you use to put again a VP shunt, please?
Yes, so I actually go through the ETV success protocol with every family before I even place a shunt, and we go through what we think the success rates are of an ETV versus the shunt and the pros and cons in their individual child. At the end of an infection, provided that the ETV success rate is about 40 to 50% or higher, I will advocate for trying one, okay, provided it hasn't already been done and failed. Because I think if we can get them a holiday without any hardware to heal their skin, to get their immune system back and to thrive, I think that is great. But if I do ETV, and it fails after an infection, then we do go to a VP shunt fairly early. And I image those kids, but if the ventricles start to increase, they've had a previous shunt, the ETV is not working, the ventricles are increasing again, I do go back to a shunt because I really want to protect that brain. I don't want it to undergo increased ICP when it just took a hit from an infection and the inflammatory cascade and everything. I hope that helps.
Thank you very much. May we move on for the next speaker, and maybe at last we continue, try to answer all these questions. Please, Noor.
Thank you so much for the amazing lecture. I'm really pleased to invite our next speaker, Dr. Federico Bianchi from Italy. He's a medical doctor at Policlinico Universitario Agostino Gemelli. He has special interest in pediatric neurosurgery, especially in cranial synostosis. He has got a lot of research in pediatric neurosurgery. You can check his very high H index on research papers. Dr. Federico, the floor is all yours now with the lecture of intraventricular antibiotic updates, when and why. So please start your lecture, and again, welcome to the program.
Good afternoon, everybody. I have to thank Dr. Kiehna because her presentation actually is a wonderful things from where to start in talking about intraventricular antibiotics. Actually, when you think things are going already bad, they can go even worse, actually, because even though most of the infection are actually from Staphylococcus aureus and so on, most of the worst infection of the ventricle are from the hospital-derived germs. In particular, ventriculitis represent one of the most important complications of following a neurosurgical procedure and shunt placement, for example, with an infection rate that range from 5 to 20%. The other cases are mostly derived from very severe case of encephalitis in smaller ICU neonates. In the major risk factors are the duration of EVD placement, especially if it lasts more than 11 days, and the frequency of EVD manipulation to take samples or medication or whatever. And intraventricular hemorrhage, as in the previously presented case, might represent a risk factor to develop ventriculitis. It's important to remember whenever putting an EVD to insert the device and tunnel it through the skin as far as possible from the surgical wound. The most important pathogens in the ventriculitis are mainly gram-negative, multi-resistant or extremely resistant germs like the Acinetobacter baumannii complex, the Klebsiella pneumonia, and so on. Or some of the gram-positive, it's worth remembering the Enterococcus faecalis resistant to vancomycin that might represent a very difficult enemy to battle against. The intraventricular therapy means the direct administration of the antibiotic bypassing the blood-brain barrier inside the ventricle, inside the CSF, in order to reach an higher concentration and with less systemic side effect. Clearly, these advantages are related to superinfection, the toxicity from the antibiotic, and the limited data we have actually in the literature about the actual and most proper concentration to use. In the literature, there are several proposed administration routes, being lumbar puncture and the Ommaya reservoir, actually not very useful to me because they can't directly treat hydrocephalus that is often associated with the ventriculitis, remaining the EVD and the external drainage the best choice in treating to deliver it. In 2017, there were highlighted the guidelines in treating the use of the treatment of the healthcare associated ventriculitis. As you can see, whenever you have to deal with the micropathogen with all those resistances, intravenous antibiotic might not be sufficient. Actually, whenever the intrasystemic antibiotic is not enough to deal with the ventriculitis, there are indications to start with intraventricular antibiotics. Whenever you have to do it, the drain should be clamped for 15 to 60 minutes after the administration in order to not to escape the antibiotics. And the dosage has to be matched with the MIC of the sensible antibiotic you have to use. Actually, there are very low evidences in the literature supporting the use of the intraventricular antibiotic despite the highlighting of those mentioned guidelines. In fact, with the grade system, as you can see, even though the confidence level is low, the actual implications are strong. Most of the people who have to deal with the particularly severe infection and ventriculitis finish to use the intraventricular therapy. Even as you can see, there are several work like this Cochrane that are actually against the use of the intraventricular therapy. In meta-analysis in 2012, the author described a threefold increase in the relative ratio of mortality compared with the patient not using intraventricular therapy. But it's worth noting that these studies only analyzed a paper from 1982, secondary to the lack of studies that met all the inclusion criteria that were evaluated. Similarly, this other study of 2014 says that there are not sufficient evidences to recommend the combination of intrathecal and systemic antibiotics, but these studies only evaluated small retrospective study. Whenever you come to what antibiotic you can administrate through the intrathecal way, vancomycin and colistin represent the major role, one against gram-positive and the other one against gram-negative, with the dosage that you can see reported in this table from treatment duration can vary a lot from few days through very long therapies that might affect the patient. For the other antibiotics, they kick in whenever you have germs that are vancomycin resistant or with specific pan resistancy against all the other antibiotics. Limitation of intraventricular therapy are mostly for two types. One is the chemical limitation, namely the toxicity of the antibiotics, and the other one can be considered as a physical limitation of the multiloculated hydrocephalus. Actually, in pediatric setting, this evidence, this happening is very frequent, especially for smaller babies, and you have to deal with it mostly because antibiotics may not reach all the compartments of the septated ventricle. As regarding toxicity, we have a whole lot of complication from chemical meningitis, seizure, nephrotoxicity, till coma and death in the worst cases. In the MR, you can see the case of a patient I saw during my residency. He was a 22 years old boy with a pituitary adenoma, a very huge pituitary adenoma, who was operated on through the transphenyral surgery. After surgery, he had several CSF leak and after that, he developed meningitis and ventriculitis. We had to treat it with the intraventricular therapy with the digoxin. That it was the first case in the literature in which it was used, due to the digoxin be the only antibiotic who was actually sensible dose Acinetobacter. After we started therapy, there was a patient complained an ascending paralysis, and MRI showed like a whole medulla hyperintensity suggestive for medullary edema, and we had to stop and to change the antibiotic with complete regression of the alteration and of the symptomatology. As for the physical obstacle, as I say, the concamenated hydrocephalus, we in our institution actually we abandoned the use of the intrathecal therapy, or at least we leave that as the last resort whenever neuroendoscopic lavage is not working anymore. Neuroendoscopic lavage can allow you to directly remove the pus from the ventricle, as well as continue with ventricular fenestration, septostomy. It can allow direct pus sampling, and it can also be repeated several times, from 1 to 4, according to Gardner in the 2018. Furthermore, it shortened the need for antibiotic therapy and the duration of the therapy, as well as fastened the CSF sterilization. It can also be argued that as most pediatric neurosurgeons already have in their tools the endoscope, it can lessen the healthcare expenses, as you will need to use costful antibiotics for a lesser length of time. You'll have to need a rigid ventriculoscope, in most cases neuroaggregation, and you have to continuously irrigate the ventricle with ringer, and you have to have a sucking device in order to remove the debris. We have, in this case, you can see how the ventricle was introduced inside the ventricle system. You can see a murky CSF with floating particle, and the aspiration device with which we wash actually the ventricle. And now we are entering an isolated compartment in the temporal horn, and you can see how it's worse the situation in this side of the ventricle with a more marker CSF, and in a few minutes we'll start to recognize ventricular wall, as well as some chunk of pus that were isolated inside the ventricle. In this way, you can, as previously said, remove this pus actually and send it to the microbiologist to check if the bacteria is the same one you previously found, or if it's another one, maybe more resistant or other things. And actually, as I was saying, in our institution, we use this technique to avoid the need to use intraventricular antibiotics. And actually, despite, in addition to what says in the treatment of the infection, some author also suggests the use of the prophylactic intraventricular administration during shunt placement as a way to reduce the rate of reinfection or reintervention secondary to infection. In this work of 2021, there was patient recovered from 100 hospitals, so almost more than 200,000 patients, pediatric patients, in which vancomycin was used during surgery at time of shunt placement. There are several limitations to the study, I think, because it's only a retrospective study in which the exact dose of the intrathecal antibiotics, as well the kind of systemic therapies that were used, are not well reported. So it might not be true for all the population in which you can use intrathecal therapy and whenever you place a shunt. Actually, in our institution, we do not use this. We don't use the intrathecal therapy during shunt placement. And finally, I'd like to present you maybe a challenging case in which, luckily, we didn't have to resort to intracerebral antibiotic therapy, because this girl was 11 years old when we came. During childhood, we was operating on with an anatomical hemispherectomy for hemimegalencephaly, and as it was done at the time, a layer of synthetic dura was placed in the surgical cavity to protect the basal ganglia. And after that, years later, she developed an infection of the residual cavity, luckily by an Staphylococcus aureus, and we managed to treat it with only intravenous antibiotics. But the real question, what if we couldn't manage to do that? What could they have done? We could have washed the cavity, or in some way insert antibiotic in the cavity to treat the infection, because obviously the removal of the synthetic material was not an option for the very dangerous neurological deficit that could have been developed afterwards. Thank you for your attention.
Thank you very much, Federico. A very interesting topic and difficult. We saw a lot of toxicity related to intraventricular antibiotics. There is some questions there. For how long, when you indicate intraventricular antibiotics, for how long you keep doing? 1 week, 2 weeks, or the time is based on CSF analysis to decide if it's 7, 14, or 21 days or more?
It's mostly linked to the responses of from the CSF sample. As I can say, as I told you before, nowadays I can't remember the last time we had to do intraventricular antibiotics. I think like 10 years, at least in pediatric neurosetting, that we avoided the use of intraventricular antibiotics in favor of the neuroendoscopic lavage. Also using maybe doing more of one time, till I think the one we did most time was 3. But after that, we managed to control the infection only with intravenous antibiotics without need for intrathecal placement of them. So in the past, I think we used to have at least a week, but as soon as the CSF sample became sterile, we dropped the intraventricular administration, continuing for a few days with intravenous.
Thank you very much. We have the same experience. After ventricular lavage, we decrease the indication of intraventricular antibiotics. maybe you can continue, and thank you very much. You can call Griselda, Nor Maria.
Thank you so much. First of all, thank you so much for the wonderful lecture. I'm now pleased to invite Dr. Griselda Ramirez. She's a wonderful neurosurgeon, a very active neurosurgeon. You might have seen her very active on the social media, answering all the questions and conducting all the webinars, etc. She's a neurosurgeon at Hospital de Pediatrica, Can Siglo in Mexico. She's the past president of the section of pediatric neurosurgery of the Mexican Society of Neurological Surgery. She's the treasurer of the Mexican Society of Neurosurgeons as well. She has always been an active, like I have already mentioned, and she's today we've got her to deliver a lecture on Neurocysticercosis. Professor Griselda, welcome to the webinar, and we're really pleased to have you. You can just the floor is all yours now.
Thank you very much for invitation. Okay, the term is about Neurocysticercosis. This is the infection of most common of the nervous system by the cyst larva of Tinea solium. We observed this infection is endemic or presumed by endemic in many low-income countries. It's the most common parasitic infection of the brain and leading cause of epilepsy in developing world. 15 million people are estimated to have neurocysticercosis and cause about 50,000 deaths each year. And the risk factors are rural areas with rural pigs, inadequate sanitary conditions, no toilet, and underdevelopment developing countries, low levels of social, economic, and sanitary development. The infection initiated with pigs, and the principal host is the human. We consider the classification of Neurocysticercosis like intraparenchymal with cis granuloma and new onset partial seizures with or without secondary generalized. Subarachnoid cisterna is the other form. Increased ICP, pseudotumor cerebri, obstructor when the patient have intraventricular cyst and meningoencephalitis, basal arachnoiditis, and these patients have psychiatric disorders and other cases. They develop dementia. In intraventricular term, racemose cysticercosis is less common, it's less 20% of all cases, but is potentially lethal. And spinal form is only 1% of all cases and mimic of intraspinal tumor. The inflammatory process and edema of prevalent extension are seen in the surrounding tissues and depend of the stage of the process. And the cysts in the brain and other tissues undergo natural process of involution or the degenerations over a variable period from few weeks to several years. The stage of neurocysticercosis, we observed for a stage. The first stage is for vesicular. We observe in hemorrhage cyst with the scolex and non-enhancement. The second stage is the form colloidal We observed an hemorrhage, ring enhancement, and empyema. In the third stage, we observed granular nodular degeneration, decreased enhancement and edema. And the fourth stage, when the cyst evolution, we observed calcification in CT scan on an hemorrhage. The clinical manifestation in patients with Neurocysticercosis, they have meningeal cysts, altered mental state, focal neurological deficits, and cysticercal encephalitis, and strokes, and sudden death. Sudden death is less common of manifestation and is associated with racemose cysticercosis. And other manifestation in these people is headache, vomiting, or focal motor deficits. And people with cysticercosis have epilepsy. 30% of patients in developing countries and 80% where it is endemic. The occlusion of small cerebral arteries may cause strokes, and a spinal cord cyst may lead to motor or sensorial deficits or radicular pain. The neurocognitive deficit is more common in childhood, and mental disorders is more common observed in adults and young adults with cysticercosis. The focal neurological deficits and signs and symptoms of space occupying intracranial lesions may also be present, and it can occur suddenly also in intraventricular cysticercosis. Intracranial hypertension causes is elevated intracranial pressure can be caused directly by obstructive or communicating hydrocephalus, large subarachnoid cyst, or a severe inflammatory response. The encephalitis often occurs in children and young women. They are infected with a substantial load of eggs, causing an aggressive reaction by the immune system against the parasites. What is important in clinical evaluation in patients with Neurocysticercosis? Neurological examination of fundoscopy. Fundoscopy can observe a cyst in retina and observed indirect signs of increased pressure. Radiological tests like CT scan is mandatory for observe the fourth stage of cysticercosis. And MRI is also important because we can observe bivalve larvae with the skull legs are seen in the vesicular phase. And blood testing is confirmatory of cysticercosis, like EITBSA is the most sensitive study for cysticercosis. In cerebrospinal fluid, we observe only in 50% of the patient have variable inflammatory reactions and anti-cysticer antibodies in the cerebrospinal fluid.
Griselda, can you talk a little bit louder, please, or close to your microphone for us to listen better what you was talking beautifully? Thank you, dear.
Okay. Parasite DNA detection in PCR has also been used with CSSP and fecal samples. The cysticercosis is a systemic disease, and we can observe in other studies like simple films observed in massless multiple cysts, and in pulmonary or chest we can observe the larvae also. And hemorrhage is useful also for observe multiple cysts inside the muscles. And the most severe form of cysticercosis is the infestation of the brain or central nervous system. Exist several criteria for neurocysticercosis. Absolute criteria is based in histologic demonstration of parasite, direct visualization of parasite by fundoscopic examination, and evidence of cystic lesions showing scolex in CT scan or hemorrhage. Major criteria are lesions suggestive of neurocysticercosis on CT scan or hemorrhage, and positive serum enzyme immunoblood site. Resolution of cysts after therapy and spontaneous resolution of single enhancing lesions. And minor criteria are lesion compatible with neurocysticercosis on image, and suggestive clinical features, a positive cerebrospinal fluid ELISA, and cysticercosis outside central nervous system. The epidemiological criteria are evidence of household contact with Tenian soleum infection, individuals coming from or living in endemic area, and history of frequent travel to disease endemic area. For diagnosis, we need conditions like two major imaging criteria or clinical and exposure criteria. One major and one confirmative neuroimaging criteria plus any clinical exposure criteria, and one major imaging criteria plus two clinical or exposure criteria. Probable diagnosis when one of the conditions to right are met. One major neuroimaging criteria plus any two clinical or exposure criteria. For treatment, what is important for patients, the first is the control of seizure. Emergent status epilepticus should be treated, and children would usually be managed with single anti-epileptic drugs like phenytoin or levetiracetam. Control of brain edema is really important because the patient have many manifestations secondary to edema. We use corticosteroids to suppress the inflammatory response at the doses of 0.15 milligrams per kilogram per day of dexamethasone for 5 days in 2 to 3 divided doses for childhood. And the most important treatment is cysticide. Albendazole is the drug of choice, and is used in a dose of 50 milligrams per kilogram per day, and is divided in 2 or 3 doses for 28 days. And praziquantel is the oldest cysticide drug, but have many collateral manifestation and worsening of symptoms of patients, and have other complications like hepatotoxicity and leukopenia. The surgical treatment for neurocysticercosis depend of the localization of the cyst. Ventricular endoscopy is very useful when the patient have intraventricular cyst in racemose variety, and BB Shunt is other technique used when the patient development hydrocephalus and obstructive hydrocephalus, or the compressive craniotomy is other procedure for treatment neurocysticercosis when the patient have cyst in foreventricle or racemose and in subarachnoid space, have a big edema. Laminotomy is other procedure when the people have spinal neurocysticercosis. Ventricular endoscopy is performed in Mexico for a long time for Professor Torres Corso in San Luis Potosí. They have many cases of neurocysticercosis in the country, and they performance not only ventricular endoscopy, they performance endoscopy in subarachnoid space for remove cyst and for treatment hydrocephalus. This is a case of patient with intraventricular cyst in foreventricle, and the craniotomy for remove the cyst and repermeabilize the ventricular system. But now this procedure is performance with endoscopy, with minimal invasive surgery. The more devastating cases is related to encephalitis and the racemose forms of cysticercosis, and have a very bad prognosis for children and young adults for extensive lesions. This is other case of intraventricular cysticercosis, and use endoscopic for remove the cyst. This is a really interesting article. Was performed 22 years ago for Singhi, about 500 cases of neurocysticercosis in children in India. We can observe the principal signs or symptoms in children. The most common is seizure, and second is headache and nausea and vomiting. And they have one lesion in more 380 cases. And the more frequent localization was parietal. And after treatment with naltrexone, they have interesting response in only 34 patients. What is the most important thing about the cysticercosis in our countries is the control and prevention, is provision of safe water, sanitation, and hygiene, integrated vector control and management, education of food handlers, instruction in good hand washing and practice, identification and treatment of dead worm carriers with albendazole, and a stool examination for tinnitus and pig immunization. development, there's several oral vaccines in different countries for control cysticercosis. Now we don't have the vaccines for children for contain the infection for cysticercosis. Okay, we need more envelope for government and health system in our countries in Latin America and sub-Saharan countries in Africa and Southeast Asia for control this cysticercosis and another tropical infections for more healthy people in our countries. Thank you.
Thanks a lot, dear Griselda. About neurocysticercosis, just one question. I have the impression that the numbers decrease a lot and is exceptional in children in the last 10 or 20 years. Did you feel the same in Mexico that we are seeing in Brazil, or did you see the same level that it was 10 or 15 years ago? I think the numbers are decreased even in the cause of epilepsy.
Okay, in Mexico, we have low cases of cysticercosis in children. It's more common in young adults, but in children is really few cases. We observe it with washing hands and sanitary and best sanitary things, and is really changing with epidemiology in Mexico, because we observed more cases in the 18th and 19th decades. In the last 15 years, we low the epidemiological cases. But it's important the governmental and health system and the sanitary procedures for low the cases.
It's great for us and for the patients too. Thank you very much, Griselda, for this very informative lecture. And please, Noor, can you introduce our last speaker?
Thank you so much. First of all, Professor Griselda, thank you so much for your very interesting lecture. I'm now pleased to introduce Professor Tony Figatti, who is a professor of neurosurgery at the University of Cape Town and the head of pediatric neurosurgery at the Red Cross Children's Hospital and Groote Hospital. He is also the secretary of the International Society for Pediatric Neurosurgery and a previous scientific chair of the organization. He is the South African National Research Foundation Chair of Clinical Research. He's also a scientific chair of the Society of Neurosurgeons of South Africa and Education Committee Chair of the Continental Association of African Neurosurgical Societies. He's one of the founding members of Global Neuro and sits on several World Federation of Neurosurgical Societies committees and will be scientific chair of the 2023 meeting of the WFNS in Cape Town. His clinical interests are in surgery for central nervous system tumors in children and intraoperative neurophysiology. His research interests are in acute brain pathophysiology in children. He runs clinical and preclinical programs using advanced monitoring in children with traumatic brain injury, which is started at the Red Cross Children's Hospital after his fellowship training in pediatric neurosurgery. We are really pleased and honored to have him today to deliver a lecture and an overview of tuberculosis of the central nervous system relevant to neurosurgery. Sir, welcome to the webinar. We are really honored and pleased to have you today. The floor is all yours now.
Oh, wow, thank you so much. Wow, that was a great introduction. Some of those things I didn't even know about. So I've been asked to speak about tuberculosis. I don't know how much tuberculosis everyone on the panel or on the webinar sees, but I want to give you an overview. And if you have any questions about any specifics, then please ask me. So why is it significant? Well, it simply is and has been for the longest time the leading infectious killer disease worldwide. So outside of COVID-19 recently, and this goes back hundreds of years we've lived with this bug. As you know, of course, the main burden of the disease, like with many of the infections, is in low and middle income countries. Most of the involvement, of course, is pulmonary, but when the brain gets involved, it obviously carries the highest risk, so it still has the highest mortality. And the way that it involves the brain or the central nervous system can come in many forms. And we'll talk about what those forms are. But neurosurgical input when it involves the brain is in fact very common and very valuable, but it's not always available. And we'll talk a little bit about that in terms of the public health impact of it. So how does TB get to the brain? We know it usually comes from the lungs. We don't know exactly for sure how it gets there because animal models don't work. The disease in children, often very young children, and adults seems to be a little bit different. And adults are very often associated with HIV disease. It's probably blood spread from the lungs. It could be venous, maybe even lymphatic. And so it has many manifestations. TB meningitis is a common variety and the most dangerous variety. So we'll spend a bit of time talking about that. But you can have mass lesions in the brain, tuberculoma, tuberculous abscesses. You can have extraaxial collections. And then it can involve both the brain, at least the cranium, as well as the spine with respect to the bones. So this is bony involvement. This is a case where you can see the whole of the base of skull here is just eaten away by tuberculosis. And it's got a large extraaxial collection there as well. And I don't think we drained this at all. We just put the child on TB medication and steroids, and you can see after several months, the bone is starting to heal. And that's usually the case once you've identified the bug and you've treated it. Occasionally, you got to go in there and curettage it, but hopefully not, because as you can see, there's a extensive involvement and you can't take out all that base of skull. The good thing about it is it responds to treatment. In the spine, it tends to be a little bit trickier because you often have these deformities with collapse of vertebrae and these cold abscesses that can retropulse into the spinal cord. And those can be difficult because you have to sometimes not all pediatric neurosurgeons are familiar with dealing with bony disease, so sometimes you have to get the orthopedic guys involved and you have to do these wedge resections, sometimes kyphoscoliosis corrections as well. And then it can involve the parenchyma of the spine. So sometimes on the very mild form, if you look on the far right, sometimes you just get this leptomeningeal enhancement. Sometimes it's a little bit thicker. Sometimes you get this extensive parenchymal involvement with syringomyelia. Sometimes you can get extramedullary involvement. Here's parenchymal again. And on the far left, you can have total whiteout of the CSF. And so these are axial examples. This is normal up at the top here. These are rootless of the chorda, these chorda equina that are somewhat thickened. Here they clump together, and sometimes you get the far right and the bottom here, just a complete whiteout of the spinal thickness, just filled with this horrible exudate. And so we've done some work. This is not terribly relevant, but it's just to make the point that the CSF from the brain may look very, very different from the CSF in the spine. And there are lots of reasons for that. If you've got some questions about why, you can ask me at the end. But these are time-linked samples. So these are samples that are taken at the same time in patients from the brain and the spine, and you don't have to know anything about differential gene expression to appreciate that this CSF is just completely different. And so when you look at the ventricular CSF, it looks completely different in terms of its expression of biomarkers of brain injury, gene expression, the cells that you see in it, the protein that you see in it, whereas the spinal CSF tends to be very heavily influenced by what's coming from the periphery And we can talk about the differences between the blood-brain barrier and the blood-spinal cord barrier, some of which explains this. But I think the take-home message is that if you take a patient, you take CSF from the brain and you take CSF from the spinal column, they look quite different. And that's important to know because it has implications sometimes for clinical treatment. And so this is these are timely examples. In the same patients, you can just see the protein, for example, and it doesn't matter. Every biochemical variable that you look at will be different. But protein is a common one that people look at. Very, very much higher in the spinal CSF compared to the ventricular CSF, and a much, much broader range. And you can imagine, having seen the spinal MRIs, why this is the case. It's important to know that. And then parenchymal lesions, they take two forms, tuberculomas and tuberculous abscesses. Sometimes they're very small, sometimes they're solitary, sometimes they're multiple, sometimes they're large. So tuberculomas, essentially on T2, they look black like this. You know, that's a solid piece of tissue there. And we don't go in and take out all tuberculomas. We only take them out if they are causing significant mass effect or they're not responding to treatment. If they're not causing significant mass effect, usually it means that the patient's just presenting with seizures, and you can treat that. Usually if you just treat them with TB meds, and it's mostly the immune response anyway that eventually treats the tuberculomas, and they go away. So it's rare that we operate on them, but of course these are selected cases where it's particularly large, and those patients ended up having an operation. And an important thing to understand about TB is that there's a huge amount of damage that is done to the brain by the body's own inflammatory response. So you see that with TB meningitis, which we'll talk about a bit later, but you see that with tuberculoma and tuberculous abscesses. Here you can see in this T2, this massive amount of white matter edema around a relatively focal tuberculoma. So very often it's this host inflammatory response that is just completely unregulated and harms patients. So those examples of little tuberculomas, you're not going to operate on these. They generally go away with treatment. Often they are multiple because they're hematogenously spread. And this is what tuberculous abscesses look like. So on T1 they're black. On T2 they're quite white, or at least isodense. Those are tuberculous abscesses, and usually you need to drain these. Sometimes you need to drain them more than once. Sometimes you need to try to take the capsule out, and very occasionally, as some colleagues of ours have published, the really, really refractory ones, sometimes you put on an anti-TNF alpha blocker like thalidomide. So that's tuberculous abscesses. And then you have meningeal involvement. So TB meningitis really is the killer. So this is the common manifestation. This is really what kills patients. Much higher mortality. The tuberculomas rarely cause more mortality or significant morbidity. Occasionally they do, but it's not that common. But the patients who die are the patients who are disabled, or the patients who present with TB meningitis. And the typical pattern is that they have this inflammatory response that causes exudate in the basal cisterns of the brain. And because it's in the basal cisterns of the brain, this exudate covers the circle of Willis as well as all the perforators. And that causes vasculitis. So pathologically, you look at these vessels, you'll see them in vasospasm, you see them, they'll have intraluminal thrombosis, they'll have a thickened adventitial lining, and essentially it reduces perfusion pressure to the brain. And then, of course, patients often have hydrocephalus, so about 80% of kids have hydrocephalus, and that further reduces the perfusion pressure. So it's no surprise that these patients die because of infarcts. They have ischemia of the brain and they develop infarcts. You can treat the hydrocephalus, and there's lots of debate about how you should treat it, but it's treatable, right? And you have to treat it and get the pressure down. The problem, though, is the infarcts due to the vasculitis. And so typically this is what it looks like. You give them contrast, and you have this basal enhancement on contrasted CT scan. You'll see that on MRI scan as well. This exudate around the hypothalamus and the circle of Willis. Sometimes you see that even on pre-contrast. These are cisterns that you usually should see. There's CSF in the cisterns, so it should be black. And so you have this pre-contrast, not hypodensity, hyperdensity. And sometimes you see that increase over time, even when patients are on treatment. And then they have variable vascular involvement. Sometimes the MRA is normal. Sometimes you have a little focal closure of a vessel. Sometimes you have massive involvement of all the branches of the circle of Willis. And so the infarcts that you see are very often in what's called the tubercular zone. So that's the core region of the brain, the diencephalon, the thalamus, the basal ganglia, the internal capsule, and the midbrain. So that's the core region of the brain where we typically see infarcts, because those are the small vessels coming off the circle of Willis. But then very occasionally you get large vascular territory and sometimes global hyperdensity as well. And this is typically what you'd see on MRI, this kind of moth-eaten brain in that tubercular zone. You have sometimes reperfusion injuries. So this is why this is quite white and T1 there. But this is the typical pattern of infarcts that you'll see in TB meningitis, or at least infarcts that you commonly see and you want to try to avoid. Hydrocephalus, of course, is common, causes either communicating hydrocephalus in the majority. So that means CSF communicates between the ventricular system and the subarachnoid space. So the CSF is getting out of the at least out of the ventricular system. It's getting into the subarachnoid space and it's getting stuck in the basal systems. Whereas non-communicating hydrocephalus, which occurs in about 15% of patients, so it's much less common, CSF is not getting out of the ventricles because it's being obstructed at the aqueduct or at the outlet foramina of the fourth ventricle. Now, for us, that distinction is really important because it changes our management, but that distinction is not always made in every center that treats TB hydrocephalus, so you'll probably hear a variety of different approaches. So this is a typical example of hydrocephalus. This patient had communicating hydrocephalus, and the way that we treat communicating hydrocephalus is that we try to treat it medically without having to resort to a shunt or third ventriculostomy, because in about half of these patients, if you treat them medically, but control their intracranial pressure, you can resolve their hydrocephalus. So this is resolved hydrocephalus. We treat with repeated lumbar punctures, acetazolamide, TB medication, and steroids. And we do the repeated lumbar punctures or an external ventricular drain to keep track of the intracranial pressure. But if you can just keep them going for a few weeks, often the hydrocephalus will resolve. And so about half the cases with communicating hydrocephalus, this works, and you can avoid long-term placement of shunt. You have to keep in mind that intracranial pressure is a real problem, even at low pressure, low levels of ICP within the normal range, because remember that these patients have vasculitis, so they're already perfusion limited. So this isn't atypical. This is a kid with brain oxygenation. And here you can see the intracranial pressure, not particularly high. Child's got a ventricular drain in. Here we lower the height of the ventricular drain, so the pressure comes down from 15 to about 6 or 7. And you can see how the brain oxygenation goes up. And here it starts creeping up again. We lower the pressure, and the pressure drop here is from 10 to 0. And that pressure range usually shouldn't change perfusion in a normal brain, but in a brain that's perfusion limited, you can see how the increase in oxygen occurs immediately. And this is another example. The drain was clamped because we wanted to put a shunt in. Normal brain oxygenation should be over 20. And you can see that this brain oxygen not only is low, but as the drain gets clamped, you can see the brain oxygenation just plummets. And when brain oxygenation gets to less than 10 or 8 millimeters of mercury, that's really metabolic stress, and you have metabolic dysfunction and high lactate pyruvate ratio. But you can see when the drain gets opened, the intracranial pressure was only 13 millimeters of mercury anyway. So that's a completely normal pressure, but in a patient with TB meningitis is a major problem. Just an example of a lumbar puncture, changing the near-infrared spectroscopy, just showing that, again, that pressure reduction works. And this is an example of one of our patients with TB meningitis who we ended up putting a shunt. And this is one of the reasons that we try to avoid shunts, because everybody knows when you manage a patient who runs into trouble with shunts, we end up with lots of scans, lots of shunt revisions. So we put a lot of effort into trying to avoid shunts where possible. And as I said, we can do that in about half the cases. All right. What about endoscopy? So people often ask me about third ventriculostomy, and this was something that I published a long time ago. It was the first time we'd looked at it. The problem with third ventriculostomy, and we'd only do this for non-communicating hydrocephalus. Lots of people just do it non-discriminately. I don't think that's a good idea. Doing it in communicating hydrocephalus, most of those patients are going to get better on their own anyway. And a third ventriculostomy in TB meningitis is much more difficult than a normal ETB because there's a thickened floor, and even when you get through the floor, when you get into the cisterns, it's just filled with exudate. So we don't recommend it. This is what endoscopy looks like in the lateral ventricle. And very often, if you look at the appendum of the lateral ventricle, you'll see it's all studded with these little tubercles. So I think it's a hematogenious spread, and it's widespread through the course of the brain. And this is the choroid plexus. It's a bit grainy because there's a bit of blood and protein in the CSF, but this is the choroid plexus, and you can see the little tubercles on the choroid plexus. And this is the choroidal artery, and you can see those little tubercles even all the way along the course of the one of the choroidal branches. And so this is what a normal third ventriculostomy would look like, right? Everybody knows this. Once you've gone through the third ventricle, you get into the prepontine cistern. This is what the cistern should look like: normal arachnoid webs. You can see the brainstem, you can see the basilar artery. It's normal anatomy that you should be able to identify. But this is what it looks like in TB meningitis. Same place, burrowing through this incredibly thickened floor. You eventually get into the cistern, and there's just absolutely no normal anatomy. You don't even know whether you're in the cistern at all. It's just all filled with this horrible exudate. So we came up with a management strategy, and we do something called an air encephalogram, where we inject air through the spinal CSF and receive it tracks into the ventricle or into the basal cisterns. If it's in the basal cisterns, it's non-communicating. But then if it's in the basal cisterns, we knew that then if we did a third ventriculostomy, you should be able to see that air, and that's exactly what happens. So this is an example, again, of a really thickened floor. Took a lot of effort to get through the floor. You can see how thick it is. Can't recognize any anatomy in the basal cisterns, but we could see air there. So we knew from the encephalogram, of course, that we're in the basal cisterns, and that we've communicated the ventricles with the subarachnoid space. And that's our goal with endoscopy, is just to communicate the systems and then treat them for communicating hydrocephalus. All right, so our approach, we have very aggressive approach to ICP treatment. We use lots of ventricular drains in the acute phase. We use acetazolamide, Lasix, all of that. We try to reduce the number of shunts. And if they've got non-communicating hydrocephalus, we do a third ventriculostomy. They've got communicating hydrocephalus, we treat them medically. If they fail medical treatment, then we put a shunt in. And so we've published a lot on that. If you want me to send you any of those publications, more than happy to do so. And happy to take any questions. That's just a quick overview of central nervous system tuberculosis.
Tony, that was a tour de force. That was really awesome. I mean, what's so great about that is that just reflects so much experience in a short period of time. I mean, that's really remarkable.
Well, thanks very much. Appreciate it.
Yeah, really something.
Fantastic, Tony. We consider neglect disease, tuberculosis. How the society can do something, the ISPN or the other neurosurgical society, to try to help this condition. There is something, about the subject that we are not doing now, and we can do in the next future, like experts in neurosurgery, not only in pediatrics. Did you see something?
Yeah, I think the advice that I would give, and this is really simple, is just to be involved. So one of the other groups that I'm involved in is an international society looking at TB meningitis, and they are filled with physicians and infectious diseases docs. And wherever they are, the common thing that they tell me is that the surgeons are just not interested. So what they do is they treat these patients with raised intracranial pressure. They know nothing about the brain. They know nothing about raised intracranial pressure and brain ischemia, but they're the ones treating them because the surgeons aren't interested. So I think if there was one advice for our community, and I think pediatric neurosurgeons maybe are a little bit more amenable to this than adult neurosurgeons, is just to get involved. So that's the one thing. And then the second thing is, especially for TB meningitis, is to recognize that these patients always have raised pressure, and their raised pressure, even at a low level, is much more dangerous than normal patients because they already have vasculitis. So really aggressive treatments to try to optimize outcomes early on in the course of the disease and get their pressure down, I think that would be incredibly valuable. But I think it's a public health problem. And I think surgeons just haven't been terribly interested in getting involved. So if I had to say one thing, it would be get involved.
I think my comments on it, Tony, is the medical school in general on the planet. We
Absolutely.
treat only pathologists. We treat only sick patients, but we are not aware what the human being behind the pathology.
Absolutely.
And one statement from Erin, she tells us, VP Shunt, there is not necessarily a problem. We have hydrocephalus, and behind the hydrocephalus, we have something behind. And usually we don't go further. We just take the patient in the operating room, we do what needs to be done, and game over. I'm wrong on these statements?
Yeah, absolutely. So, Rick Boop was in town with me, and we had this conversation this morning. As surgeons, we want to operate, and so we are interested in kind of most of my operating is for neuro-oncology. So those are the things that we like to do. We like to take our craniopharyngiomas and pineal region tumors and spinal cord tumors. But the reality is that we would, and we should do that. So I'm not giving that up at all. But the reality is that when we look at the potential public health impact of the things that we can do, and Jeff is a great example of this in spina bifida, is that when we start focusing on the public health aspect, the actual patient, we end up actually doing a hell of a lot more for many, many more patients than we would just by our operating. And I think because we know the brain so well, I think we should have a responsibility for the operating, but we should also have a responsibility for the public health opportunities that we have, and we have lots of them. And as you say, it's about the patient. So that's a good example of how we can maximize the benefits to our patients.
And Tony, I think this is a great place to have somebody like you say something like that, because there are currently about 115 people in some way or another connected to this. And most of them are younger, junior doctor, trainee level people. And I think it's in talking to those audiences that we gradually affect a subtle paradigm shift. Absolutely. And the way you said it is spot on. Nobody is suggesting that as surgeons, we surrender our capabilities to acutely intervene for the person in trouble. We still want to help that person. But in the process of doing that, over time, we have such a front row seat to the suffering that's associated with these conditions that if we're at all awake, we have to ask ourselves, is there something upstream that we could use our position, seeing the misery, to share and say, hey, society, let's reduce head injury. Let's do the simple stuff. Let's reduce prematurity. Let's fortify, with folic acid. Let's, these relatively simple things that can have a big downstream effect while we still are trying to help kids with the surgical problem. And that bring you, somebody like you, who's dynamic and whatnot, in front of a crowd of young people, that's hopefully the paradigm that's going to change. We hope that the young people will recognize the impact they can have by grasping some of the public health component of this and just making that part of their training, just like they know how to dose seizure medicines or pain or nausea or whatever else.
Yeah, it's a great, it's one of the great things about the profession that we're in, is that you can do it all. You can do great surgery, you can do great science, and you can make this incredible public health impact. And the value of that was driven home to me earlier this year. I was invited to give a lecture at the Society of British Neurosurgeons, and it's a named lecture by Sir Hugh Cairns, who's one of the famous British neurosurgeons of like 70 years ago. And I didn't know too much about him, and I knew a little bit, so I read a little bit more about him. And it's a fascinating story because he treated Lawrence of Arabia.
Oh, wow.
And now the younger people of the audience might not know Lawrence of Arabia, but that was a major movie kind of many years ago. This incredible story of the Brit in the Arabian region, and it's an amazing movie with Peter O'Toole playing the role. But he was this dynamic force, this Lawrence of Arabia, and he came back to the UK after this incredible life, and he was involved in a motor vehicle accident. And so he had a severe head injury, and Hugh Cairns was the neurosurgeon who treated him. But he failed, and Lawrence of Arabia died because of a head injury from a motorbike.
That's how the movie closes, Tony. The movie Lawrence of Arabia closes with him zipping through the English countryside in his little MG or whatever that sports car is, and after he's done these spectacularly dangerous things of going across the desert to, wow.
And then he dies in a motor vehicle accident. And so Hugh Cairns, he says it changed his outlook. And then he dedicated his life to a public health campaign to enforce the wearing of motorcycle helmets. And at the end of his career, he said, look, he operated on kind of so many patients. He had a great science career. He published a lot. Interestingly enough, he even published on tuberculosis meningitis. But he said his greatest gift to humankind in terms of what he accomplished was his public health campaign. And I remember that, and it's just as you said, it's a great example of the fact that we can do it all. We can have this wonderful professional career where we do challenging surgeries. We at the nexus of clinical health and science, so we can do great neuroscience. But most importantly, we can have this incredible public health campaign, as you've demonstrated with spina bifida. And the truth is that you will accomplish more in your work with spina bifida than you would have ever accomplished in the operating room.
In terms of sheer numbers, yeah, and that's that's not me. That's a big group of people. But
yeah.
Hey, Nelci, do we have to wrap, or can I pose one question or observation to Mr. Sinha?
Yes, we have 15 minutes overtime, but we have one question also.
Yes, please. Please.
They ask about steroids, what the role of the steroids, even in empyema and abscess, and also in tuberculosis. Maybe you can just answer the question, Ajay and Tony.
I mean, we don't use steroids regularly in pyogenic abscesses and empyemas. I don't think we have used it, but there isn't any class 1 evidence in this regard. For TB, meningitis, and we have used it, and we tend to use prednisolone because what it does is, I'm sure Tony will have a greater experience on that. We tend to use prednisolone, and with prednisolone, the protein content starts coming down, and then in a better position to shunt or do endoscopy. So for empyemas, abscesses, we don't use it. I know there are various other groups who have been using it, but I don't think there is any class 1 evidence of its use. So we don't use it in our practice, and we don't regret not using it.
Thank you.
Yeah, so in TB meningitis, there's pretty good class 1 evidence. There's a randomized controlled trials, both in children and in adults. And so it definitely decreases mortality. The interesting thing though, and we just use it for 1 month. So in the first month of therapy. The funny thing though about TB meningitis is that we don't know how it works. So in those randomized controlled trials in the adults, in the the arm randomized to steroids and those randomized not to steroids, when they looked at their cytokines in the blood and in the CSF, they looked exactly the same. Because the theory was that surely the steroids dampens down the inflammatory response, but they weren't able to demonstrate any difference between the two. And my pet theory, I suspect, is that these patients are relatively steroid deficient because of all the ischemia around the hypothalamus, because that's where the exudate is, it's around the hypothalamus. And when you have critical illness, you know, patients who are steroid deficient, when they have critical illness, you've got to give them steroids to overcome that. And I suspect what we're doing is maybe just propping up the hypothalamus during the critical illness. But whatever the mechanism of action, it seems to work in TB meningitis.
Thank you very much. Jeffrey, you may wrap up the webinar. And your final question, maybe.
Yeah, I would just say that it's been a great session. I think we've had some really wide-ranging talks. The talk about shunts was absolutely comprehensive. The talk about abscesses and empyema is so important to keep them separate and jump on those empyemas, know that they can recur, know that they're a surgical emergency. Tuberculosis, meningitis, I mean, just a robust demonstration of the wide clinical spectrum. Intrathecal antibiotics, a modality that is probably to this day underutilized and understudied. A very nice presentation of that, and of course, Neurocysticercosis, just a devastating injury in so much of the world, devastating condition in so much of the world. The speakers have done a great job. We still have a robust audience in excess of 100 people. Thank you all for your time, your expertise, very good lectures across the course. We're delighted and pleased to have all of you. Thank you so much. And to the listeners, make sure that you complete your forms so that you can get credit. For everybody, please make sure that you attend to the guide and other references that are put together for you. And we hope and look forward to seeing you on the next webinar in 4 weeks. Any other points, Nelci?
Some final words, Noor Maria?
Thank you so much for having me here. It's a matter of huge pleasure and honor for me to be a part of this amazing webinar. I really want to extend my heartfelt thanks to Professor Nelci, who has been doing so much for neurosurgery and for the junior neurosurgeons, and she has been really a source of inspiration for all of us. I really want to thank her for all the support and motivation that she has got, and even myself, being a young neurosurgeon from a low-middle-income country, I can feel that their contribution of all the wonderful mentors that have presented, that have spared their precious time to deliver lectures for neurosurgeons all around the world. It is so big. We owe you a lot, because we think that during this pandemic we were quite worried that it is the time period when you just complete your training. It is the time period when you have high hopes and you're in high spirits to learn more. And during that time, unfortunately, many of us were affected with all these emergencies. Our hospitals were converted into more COVID units. Our elective lists were suspended. We never had grand rounds, and even now we are slowly getting back to normal, and that's not even the normal that we used to have. But I think that it is all because of the mentors like all of you who have contributed to neurosurgical education even during these very challenging times. So I really want to thank everyone and all the teachers today who delivered their magnificent lectures for all of the neurosurgeons all around the world. This journey has been really amazing. It was really bumpy for all of us to go through all these challenging times, but I think that even every cloud has a silver lining. So I think this webinar system, all these virtual platforms were quite helpful, and I think that the pandemic actually highlighted a very important source of information or an untapped potential that I think that we couldn't otherwise find. So I think that it has been really amazing. So I really want to thank everyone, and I really want to extend my regards and best wishes from Pakistan.
Thank you very much for all the speakers that are set to give your time and energy on the last minute. Tony, Erin, Federico, Ajay, I know the schedule is tight for every one of us, but the audience keep with us and giving us courage to continue to work. Griselda, thanks for being with us, and the support of Linda from ISPN office is special for us to keep it going and working. And thanks, Jeffrey, for all your support, and Nor Maria for working together. It's a great time for us, and the audience is the reason for being here with you. Thank you very much, and see you all on next last Friday of November. We will have a special webinar in head trauma, and after in January in epilepsy. And thanks again.